Okay, our next speaker will be Darron Brown, who will be addressing the important issues of cross-protection and also duration of protection for the current vaccines.
Here are my disclosures and potential conflicts of interest. And there's a few there related to some work I do with Merck and the scientific advisory board of a small biotech company named PDS. I'm going to talk about cross-protection of vaccines today. This is a subject I've spoken about a couple of times before, and there's a lot of interest in this because while the vaccines were not specifically designed or manufactured in any way to produce cross-protection, it's theoretically possible that this could occur because of the large degree of homology between certain species of HPV types and the neutralizing epitopes. And this is an important issue from a business point of view. There's a lot of people very interested in this subject, and when we first started looking at this in 2009, it was a very exciting thing to do. The definition of cross-protection that we use is a working definition I provided for you here. These 12 other oncogenic types that we'll talk about each contribute a small percentage to the total cervical cancer burden. Here's kind of the species chart, and you can see some of the relatives. The A9 species include 16 and its close cousins, 31, 33, 35, 52, and 58. The A7s include the prototype HPV 18 and its close cousins 39, 45, 59, and 68. HPV 51 and 56 are also oncogenic types that are assayed for in the standard PCR assays that are used in the trials of both of the vaccines, but these are not A7s or A9 species. Here's some of the important questions that I think we need to consider when we discuss cross-protection. There's actually some others, but because of limitations of time, we're going to try to focus on just some of them. How robust and consistent is cross-protective vaccine efficacy compared to that against HPV 16 and 18? How do HPV 16 and 18 co-infections potentially affect calculations of cross-protective efficacy? What are the differences in the vaccine trials? What are the effects of differences in the vaccine trials of cross-protective efficacy? And some of these differences I'll point out to you, including population differences and assay differences and the like. And based on the available evidence, which there isn't a whole lot of, what is the duration of cross-protective efficacy compared to that against HPV 16 and 18? The populations that have been used to study cross-protection are the ones that ostensibly have the least amount of prevalent infection at the time of enrollment, either at baseline or screening. And so PCR assays have been developed to look for evidence of infection at baseline or screening for a variety of types, including the 14 oncogenic types in the case of GSK's assay, or 12 oncogenic types plus 611 in the case of Merck's assay. And serological assays showing negativity at baseline, and of course the assays differed between the two trials as well. And Joachim pointed out a little bit of the differences that assays can impart on determination of such things. Specimen collections as well in the case of the quadrivalent vaccine, cervical, perianal, and vulvar specimens as opposed to the bivalent vaccine where there were only cervical specimens taken. And in that naive population, of course, they have to be given at least one vaccine dose, but in some cases two. Here's the 6-month vaccine efficacy against 6-month persistent infection. This is data from Tavia Malagone's paper in Lancet Oncology this summer. And as you can see, there's a very high degree of vaccine efficacy for both of the vaccines. And you can see this on the right-hand side. I don't have a pointer, I don't think. There is one, but in any case, you can I guess it won't work. But you can see the high degree of efficacy against 16 on the top right and 18 on the bottom right. And there's a very high degree of consistency between the trials. The top is Future 1 and 2, and then you have the phase 3 trial, Patricia, of the bivalent vaccine, and 2 phase 2B trials, 007, and then 023, which is a subset of 007, the Brazilian cohort. And you can see a very high and consistent level of vaccine efficacy. And HPV 16 and 18 are the primary drivers of cervical cancer and precancers, and therefore it may be assumed that HPV 16 drive the development of high-grade cervical lesions when present in biopsies that also contain non-vaccine oncogenic types. And if cross-protection is really robust, we should see differences between vaccine and placebo recipients and CIN2+ lesions that are also that are not co-infected with HPV 16 or 18. I don't know how to get rid of this to make this the full, perhaps oh, I see, never mind, it's working fine. So this is quadrivalent vaccine efficacy against non-vaccine types, and this is some data that we published in 2009. And as you can see, the composite of 10 oncogenic types, we found a vaccine efficacy of 32.5%, but this included lesions that were co-infected with HPV 16 or 18. Similarly, in the TVN population, this is the total vaccine cohort naive population, which is similar in scope to the HPV naive population that was used in the trials of the quadrivalent vaccine. You see approximately a 56% vaccine efficacy with significant confidence intervals. But if you compare them, so here they are again, the 32% and the 56% when we include lesions that are co-infected with HPV 16 or 18. But what happens when we exclude those? And this data we presented last year in Berlin, and Tibia Malagone has this in her paper as well. We now see loss of statistical significance for both the quadrivalent and the bivalent vaccine in terms of cross-protective efficacy. Because HPV 16 and 18 are the primary drivers of high-grade lesions, if many CIN2 lesions in the placebo group contain HPV 16 in addition to non-vaccine types, then the apparent cross-protective efficacy will be higher. And this is because estimates of vaccine efficacy for cross-protection is weighted by the high efficacy of the vaccines against HPV 16 and 18. Next, I want to talk briefly about how differences in the vaccine trials may affect the calculated cross-protective efficacy. And there's really two possibilities. One is that there really are true differences in vaccine efficacy against non-vaccine types amongst HPV naive women, or there could be some factors that are really not related to vaccine efficacy alone, such as differences in the characteristics of these populations. For example, different countries were used, and I think this is important to consider in the trials of the two vaccines. One important difference, at least potentially important difference in my mind, was the number of women from the Asia-Pacific countries. It was 34% in the bivalent trials versus 4% in the quadrivalent trials. There are some other important differences as well that can be discussed later if time allows. There are also differences in the baseline incidence and prevalence of HPV infections in the naive populations. And last but not least, there were differences in the assays used. The PCR assays were different, the serologic assays were different, and to me, it's very difficult to really be sure that you can compare trial A to trial B when there's such marked differences between some of these parameters. This is data from Cosette Wheeler's paper looking at this is the recent paper that they published in Lancet Oncology, and I don't know if Cosette's here today. I did not see her, but she's a dear friend of mine, so I don't want to say anything bad about Cosette. I love her paper. What I have a hard time sometimes understanding, though, is what we have here is CIN2 or CIN3 that includes HPV co-infections, and as you know, there's a statistically significant 91.4%. This is the bivalent trial, and this is in the TVCN population, again, the HPV naive young women. And when they excluded 16 and 18 infections, they lost statistical significance against CIN2, but they retained it against CIN3. There's a couple of things that I have a little bit of hard time with. This is 11,000 women, and we have a total of 13 cases. So even though it's statistically significant, I think just the number of cases is very small. There's a wide confidence interval. And in this table, what I did here is summarize the individual types, and you can see the very high level of significance for HPV 16 and 18 in this study. And this is a combination of Matti Lettinen's paper and Cosette Wheeler's. But for the individual types, over here is the HPV 16-18 that excludes co-infection, and here's CIN2. And the only one that has statistical significance is HPV 31 and HPV 33. And unfortunately, this 11-to-2 split that gives you that 82% efficacy against CIN3, they don't report any of the individual types. So this has been an issue for me to try to sort out what's driving that 11-to-2 split. So I have a bit of a hard time with that, and I've not been able to resolve that to this point. This again is data from Tivia Malagone's paper, and this is a really nice way to present this data. And what she did here was looked at 6-month persistent infection for HPV 31, 33, 45, 52, and 58. And the top is the future 1-2, and you can see that there is significance here for future 1-2. And Patricia, there is significance. In the phase 2 trials, 007 and 023, there is not significance, but the numbers are relatively modest. So there's not a whole lot of data points, but there is a bit of inconsistency in this data. If you look at HPV 33, kind of the same thing. HPV 45, there is no significance for the quadrivalent vaccine. There is in the Patricia trial, the bivalent vaccine, but then we have some inconsistency here in the phase 2 trials. So what they tried to look at is the homogeneity of these trials, which is the percentage of the variation that's not due to chance alone here. And you can see there is quite a bit of variation for persistent infection. And when we look at CIN2, again, here's HPV 31 here. And so for future 1 and 2 that includes 16 and 18, we see significance as borderline significant when we exclude. In the Patricia trial, we have statistical significance both including and excluding 16 and 18, which is not seen in 023. And you can go down the line and look at these in her paper. It's really quite good. For Patricia here, you can see in the bivalent they have good activity against CIN 2+ that includes and excludes HPV 16-18, but that's not borne out in these longer term trials, these phase 2 trials, that include less people. An important question is, what is the duration of cross-protection? First of all, if you believe that there is cross-protection, do you think it's as rigorous as that against 16 or 18? Well, no, the vaccine efficacies don't look to be even close. But when we talk about duration, there's really not much published data available, and antibody levels are quite low for non-vaccine types after a few years compared to vaccine types. And as Joachim pointed out, in vitro models, you need considerably higher titers, anywhere from 10 to 100-fold higher, to afford neutralization in such models as the pseudovirion-based neutralization assay. So there is some concern that duration might not be very long-lasting. There is a little bit of data available from the trials of the bivalent vaccine, and I've had some pushback when I've presented this slide, but I think it's the only thing that we have, so I want to explain it so there won't be any misconceptions, and I'm not trying to pull the wool over your eyes. I'm simply showing you what's available that we have. So this is the Patricia trial here, which is obviously the phase 3 trial. And as you can see, the vaccine efficacy against 16 and 18 at 48 months is very high. And it's also pretty good against 31, 33, and 45 at 48 months. Now, these are the two phase 2 trials that are on this slide, and study 007 derived from study 001, and these were young women in one of 3 countries, Canada, US, or Brazil, that had received all 3 doses and were followed up to 6.4 years. And as you can see, vaccine efficacy with 6-month persistent infection is extremely high for 16-18 combined and 16-18 individual, but there is no efficacy now in this 6.4-year follow-up trial against 31, 33, or 45. And 023 was the Brazilian subset of study 007 that was followed. Actually, it's up to 9 years. And again, we still have excellent protection against persistent infection for 16-18, but we don't have protection against these non-vaccine oncogenic types. So in summary then, HPV vaccines show high, long-lasting efficacy against infection and disease caused by HPV 16 and 18. The quadrivalent vaccine protects against persistent infection with HPV 31. The bivalent seems to have protection against HPV 31, 33, and 45 persistent infection, although there's a large degree of heterogeneity among the studies for HPV types 33 and 45 for the bivalent vaccine. Regarding CIN2+, the quadrivalent vaccine appears to protect against CIN2+ due to HPV 31. The bivalent seems to afford reasonable protection against CIN2+ due to HPV types 31 and 33, but I don't feel the data is conclusive about HPV 45. And again, you can look in Malagone's paper and make your own decisions about this. For both vaccines, vaccine efficacy against these non-vaccine types is less than that against CIN2+ due to vaccine types. And lastly, although there are differences in relative risk reductions, the effect of vaccination is measured by the number of cases prevented, which I didn't go into, and Suzanne alluded to this a little bit. And I think this concept of absolute risk reduction is quite important. I left out some of the numerical calculation slides just because I'm out of time. And, but maybe afterwards, if people want to discuss this, I'll be happy to do so. And while extremely limited, so I don't want to push this too hard because, like I say, I've gotten some pushback from some individuals, and I know this is an important issue, so I don't want to overemphasize it. But the limited data that we have suggests that duration of cross protection may be considerably shorter than that afforded against vaccine types by both the quadrivalent and the bivalent vaccines. And so I will stop there. Thank you very much.